So we'll continue with our review series on the ECG. In this particular video, we're going to be looking at left bundle branch block. Today, I actually want to release two videos, so I will release this one as the first video. The next video, we will look at the RS wave progression. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at left bundle branch block. This is part of our ECG bootcamp. If you haven't yet watched the previous videos, please head over and watch those videos. So if you haven't watched part 1 up to part 4, I would advise you to pause the video right now, start watching part 1, watch part 2, part 3, part 4, and then come watch this because it's not going to make sense to you. I don't know why you're still here. Go and watch those videos if you haven't. Right. So remember in our 7-step interpretation of our ECG to make sure we don't miss out any pathologies. Step 1, we look at the patient and the ECG details. Step 2, we look at the ECG calibration. Step 3, we look at the general impression. Step 4, we're going to be looking at the rhythm interpretation. So pretty much the regularity, the rate, the P wave, the PR interval, the QRS complex, as well as the overall interpretation of the rhythm. Step 5, we look at the QRS complex interpretation. So we look at the axis. We looked at the right bundle branch block in our previous video. In this particular video, we're going to be looking at the left bundle branch block. And in the subsequent video that I will post as well, we're going to be looking at the RS wave progression, and we'll only be left with 2 steps to complete interpretation of the ECG. So remember from our basics, the heart has a property of automaticity because the SA node is going to be generating this impulse that controls the heartbeat. So this impulse is going to be generated in the SA node, and this impulse is going to spread and depolarize the right atrium first, and then this is going to spread over and depolarize the left atrium as well. Eventually, this impulse is going to be carried from the SA node to the AV node through the internodal tracts, and eventually from the AV node, this is going to be carried to the bundle of His. Remember that the bundle of His is going to be dividing into the right bundle branch and the left bundle branch. And as we spoke, even in the previous video, we established that the depolarization is going to be starting from the left bundle branch and then is going to spread to the right bundle branch. And remember that your left bundle branch has an anterior fascicle and anterior division, and it also has a posterior fascicle or posterior division. So remember that if your current is now flowing through normal pathways, it's flowing from the SA node through into the internodal tracts, it's reaching the AV node, then eventually the common bundle branch, then the right and left bundle branches, then it's going to be following a normal pattern. So even your QRS complex is going to be appearing normal. It's going to be of normal duration. It's going to be roughly about 1 to 3 small boxes wide. You're going to have your P wave, and of course it's going to be married to the QRS complex. So if there's any abnormality in the conduction either down the right side of the bundle branch or the left side of the bundle branch, this is going to result in depolarization of the muscles a bit late. So this is going to cause that depolarization of the ventricles to delay to some extent, and this will cause widening of the QRS complex. So they will appear broad. So in a normal heart, the time it takes for the depolarization actually to spread from the interventricular septum to the furthest part of the ventricle should be less than 120 milliseconds. So that's less than 3 small boxes on the ECG. So if it's greater than 3 small boxes on the ECG, it means that your ventricles are conducting this very slowly and the electrical activity is flowing through an abnormal pathway. It's not really flowing through the normal usual pathway. So the wide QRS complexes could be pointing towards bundle branch blocks, but also it could be meaning that the impulse is actually starting off in the ventricles in some cases. So remember that if it's a sinus rhythm with a bundle branch block, you're going to have your P waves, you're going to have your narrow QRS complex, and even your PR interval will be constant. But if you have blockage of both bundle branches, this is similar to actually having a 3rd-degree heart block. I'll talk about heart block in this particular lecture because I realized that when we're talking about the PR interval, I didn't mention about that in detail. So we'll talk about heart block in this particular lecture as well. So remember, you could have the right bundle branch being blocked, you could have the left bundle branch being blocked. If you have the right bundle branch being blocked, you're going to see certain characteristics that we talked about pretty much in lead V1 and lead V6. Then left bundle branch block almost always is going to be indicative of heart disease. So usually diseases that are affecting the left side of the heart. Right bundle branch block could be normal in some patients, but it could also indicate that there is some disease on the right side of the heart. But left bundle branch block, almost always there is a problem with the heart. So it's important actually to recognize these bundle branch blocks, because remember that if you have a left bundle branch block, you're not going to be able to interpret your ECG any further. If you have a right bundle branch block, it may make your interpretation of your ECG a bit difficult. So you should pick these up when you're interpreting your ECG. So key things to remember, which I did talk about in the previous video, they do apply for this video as well. So number one, remember your septum is going to be depolarizing from the left side, going towards the right side, then eventually moving towards the apex of the heart, then the lateral aspects of the ventricle. The left ventricle has a greater mass than the right ventricle, so meaning it's going to have a greater influence on the ECG than the right ventricle under normal circumstances. But here, remember that the left bundle branch has been blocked, so it means that this is going to be reversed. The spread of the current is going to be moving from the right side to the left side, even despite the left side having a greater muscle mass, because the pathway which is meant to carry this impulse towards the left side of the heart has been blocked. Then an electrical impulse is going to be spreading towards a lead, and it's going to cause a positive upward deflection in the ECG. If it's moving away from that lead or electrode, it's going to be causing a negative deflection. So the leads that we look at best to determine bundle branch block are V1 and V2, which look at the septum, and V6, which looks at the lateral aspect of the heart, to some extent even V5. Remember, I've already talked about how these ventricles are depolarizing. You're starting off at the SA node, then this impulse is going to reach the AV node. From the AV node, the common bundle branch, then it's going to first depolarize the left bundle branch, and then there's going to be an impulse that's going to be spreading towards the right bundle branch. Eventually, this impulse is going to be traveling and moving towards the apex of the heart. Then eventually it's going to be moving in the lateral aspects of the ventricles. That's how your QRS complex is actually forming. I actually talked about this in great detail when you look at the first part of this ECG bootcamp. So let's talk now about left bundle branch block. We already established one important thing. Number one is that your impulse is normally being generated in your SA node, and this impulse is moving through the internodal tracts, and it's eventually reaching your AV node to depolarize the ventricles. And remember, under normal circumstances, you're going to have your left side depolarizing first, and there's going to be a current that is going to be flowing towards the right side. So from the left bundle branch, it's going to be flowing towards the right bundle branch. Now, when this happens, you remember there are two important leads which are sort of like opposite each other. You have lead V1, which is looking at your septum, and V6, which is looking at your lateral aspect of the heart. Remember that this impulse is going to be flowing towards V1 under normal circumstances. So from the left side going to the right side. So under normal circumstances, you expect to see a Q wave, a small Q wave in your lateral leads. So you expect to see a small Q wave in lead 1, in lead AVL, in lead 5, in lead V5 and V6 rather. You expect to see what is known as a septal Q wave. This is normal. But now, in the case where someone now has a left bundle branch block, remember that you have an impulse coming through your AV node, and it's supposed to go first and depolarize the left bundle branch, and you're supposed to spread this impulse to the right bundle branch. So instead of you having your Q wave here in V5 and V6, as well as lead 1, lead AVL, you have absence of the Q wave. So it means that your Q wave is not going to be there in lead V6. In essence, the opposite is going to happen, because now it's like the impulse is going to be spreading from the right side going towards the left side. So it means that if it's moving away from this lead, which is on the right side, V1, you're going to have this small Q wave. So you're going to see some Q waves that you may see in lead V1. And because this impulse is spreading from the left side, rather from the right side going to the left side, it's going to cause your R wave to be present here in V6. So you're going to have a Q wave that's present in lead V1. You're going to have an R wave that is present in V6. That's what's happening. And these are the stages of ventricular depolarization in someone who has a left bundle branch block. Now, remember that your right ventricle is going to depolarize before your left ventricle, even though the right side has a smaller muscle mass, but remember that the left bundle branch has been blocked. And by virtue of this left bundle branch being blocked, it means that your right side will depolarize first, then there'll be a bit of some time, the impulse will now spread towards the left side to depolarize the left side as well. So you should see some abnormalities on the ECG. So remember, we already had our small Q wave in our lead V1 and we had an R wave in our lead V6. So now, when this now actually happens and the right ventricle depolarizes, you're going to get something that is very characteristic. So after now your Q wave has formed and there's some depolarization of the right ventricle, you're going to have another wave that is going to be forming on your lead V1. So you're going to have your V1 having an S wave, and then eventually you're going to also have your lead V6 having an R wave, because there's going to be some impulses that are going to be flowing in that depolarization. Now, that's with the right ventricle. So when the right ventricle has depolarized, you're going to have an R wave that we're going to see in our lead V1. So eventually there's going to be another positive wave, as you can see here. So there was initially a Q wave here, then there's going to be a positive wave, which is this R wave that we have here. And then on the opposite side here, you initially had an R wave, and then there's going to be a small notch here that you're going to see on your V6. So you're going to have your initial Q wave, so you're going to have your initial Q wave, you're going to have your R wave, then eventually you're also going to have an S wave here in V1 because of how this is happening. Remember that the depolarization is going to be happening first affecting the right side, then the left ventricle is also going to depolarize. So it would be like these QRS complexes are stacked close to each other or stacked next to each other. So instead of you seeing those rabbit ears that we talked about in the previous video, in V1, you're going to see the rabbit ears that are going to be appearing in V6. So as you can see, you have these rabbit ears. So you can sometimes just have a notching of V6, and then you know that this first wave here is because of depolarization of the right ventricle. Then the second wave here is going to be because of depolarization of the left ventricle. You also have, so this is what's known as an M pattern. Then you have an opposite thing that you could think about. So you have a W pattern that you see in V1, but this may sometimes not be there. Sometimes you may see some T wave invasion in the lateral leads, so in lead 1, in lead V5, V6, and as well as V2. And of course, like I said, you won't have your Q waves in V1, which normally should be there in V1. You don't have your septal Q waves in V1. So what are the key things to remember? Remember that right bundle branch block, you best see it in lead V1, where you're going to see your RSR prime pattern. Your left bundle branch block is going to be best seen in V6, where you're going to be seeing these broad QRS complexes that may have a notched top, or you may have this M pattern. And in V1, you may see this W pattern. So this is what it looks like. So here we have our M pattern, or rather an M pattern here in V6. So as you can see, an M pattern. So the first positive deflection is because of depolarization of the right ventricle. The next deflection is because of depolarization of the left ventricle. So we have an M pattern in lead V6 and we have a W pattern in lead V1, though this may sometimes not be seen in V1. So what's our diagnostic criteria for left bundle branch block? So you're going to have a QRS complex that is broad, greater than 3 squares. You're going to have a dominant S wave or a deep S wave in V1. You're going to have a broad monophasic R wave in the lateral leads, so lead 1, AVL, V5, V6. You're going to have absent Q waves in your lateral leads, again lead 1, AVL, V5, V6, and you have a prolonged R wave peak time greater than 60 milliseconds in leads V5 to V6. What do you do when you see a left bundle branch block? So you should think that there's some aortic stenosis or maybe some ischemic disease. If the patient is asymptomatic, there's no action that is needed. If the patient has recently had severe chest pains, then it means that they may have had a myocardial infarction, and even thrombolysis could be considered in such a patient. Remember that in these patients, we're going to be treating the patients and we won't be treating the ECG. So here's an example. I want you to pause the video and use the 6 or 7 steps that we have covered. I know we haven't yet talked about hypertrophy, we haven't yet talked about ischemia, but use the steps that we have covered so far to interpret this ECG and tell me your findings. You may pause the video right now, increase the quality on the video. And here comes the answer. So remember in our steps, our step 1 is of course your ECG details. Of course, we don't have ECG details here. We don't have the patient name, when this ECG was done, the file number, and the date and place where this ECG was done. The calibration is standard, it's normal. So 1 box wide, 2 boxes tall, so that's standard calibration. When you look at this ECG from a glance and you look at it quickly, we can see that these Keras complexes don't look normal. They look broad, they look bigger than 3 small boxes. So there is ugly morphologies and the Keras complexes are broad. If we actually look at the RR intervals, we can see that this RR interval here on our rhythm strip is not the same distances. This here is not the same distances. This here is not the same distances here. So it's irregular, and we can't even pick out any pattern that is going to be occurring in this rhythm. So it's an irregularly irregular rhythm. So remember, for our irregularly irregular rhythm, we're going to be counting the Keras complexes on our 6-second strip. So we can count from the beginning here, from the beginning over here, we can count about 30 squares. So if we count about 30 squares, maybe it ends somewhere here. We count the Keras complexes 1, 2, 3, 4, 5, 6. So we have 6 Keras complexes in our 6-second strip. So we multiply that by 10, because that's how you calculate the rate in the rhythms that are not regular. Remember, if you don't understand this, it means you have skipped a part of this ECG bootcamp. That's why you're not understanding, and that's why you're not getting this. So this now means that this person has a rate of 60 beats per minute. Most likely, this is a ventricular rate that is happening. There's some sort of escape that may have happened here. So if we look at now the rhythm, we can see that there are no P waves. We can see that there are some deflections here, but you can't identify one single P wave. So here you call these as F waves. So most likely this person, the atria is like it's shivering. It's not creating one impulse. Then our Keras complexes, like I said, are broad. They're more than 3 squares. Then look at the cardiac axis. In lead 1, it's facing upwards. In lead 3, it's facing upwards. Lead AVF is facing upwards. Lead 2, it's facing upwards. So this is most likely a normal cardiac axis. Then we come and now look at any presence of any bundle branch blocks. We come and look at V1. V1, what is characteristic? We have these deep S waves that we can see in V1. We have another deep S wave we can see in V1. We have another deep S wave we can see in V3. And then we have the tau R waves that we can see in the lateral leads. As we can see, we have tau R waves in lead V5. V6, we have tau R waves there in V5 and V6. And then in addition to that, you can see what's happening here in V5. We have this notching of the Keras complex. Even here, to some extent, there's a bit of notching of the Keras complex in our V5 and V6. And of course, you also have some slurring of the S wave here in V5 and V6. So looking at the RS wave progression, all the leads here, lead 1, 2, AVL, AVF, lead 3 are facing upwards. We can see that the Keras complex in V1 and V2 is predominantly downwards. In V5 and V6, it's predominantly upwards, so that you have a normal RS wave progression. So if you were to actually think of this ECG, 2 significant findings that are there is that you have a left bundle branch block. You also have atrial fibrillation in this particular patient. We haven't yet commented on hypertrophy, if there's presence of any hypertrophy or any presence of any ischemia or infarction. We haven't yet done that, so I will not comment on that in this particular video. We'll do that a bit more when we look at the end of these particular videos. Coming now to our second example, you may pause the video right now and work this out. If you don't work this out, you're not going to get the principle. And if you don't get the principle, ECG will continue being hard for you. So the first step is looking at the ECG details. As we can see, we don't have the details here, but of course, when this ECG was done, where it was done, the name, the age of the patient. We come to look at the calibration. It's standard, even though we're going to struggle to look at these small squares here. We can't really view them, but we assume this is 1 big square and 2 big squares tall. As you can see, even here at the inscription here at the bottom, it's moving at a speed of 25 millimeters per second. 1 millivolt is equals to 10 millimeters. So it's a standard ECG calibration. We look at the general impression of this ECG. We can see that there are some ugly morphologies that we can see just quickly by glancing at it. They are also broad. The QRS complexes are more than 3 small boxes. When we look at the regularity, is it regular? We measure the distance from here to here, from here to here, from here to here. We can see that the distances are rather the same. We now come and look at the rate. We can actually count the boxes here. So if you count the boxes, it gave me somewhere around 23, but it may be a bit inaccurate because I can't really see the small boxes so well. So the rate is roughly at around 65 beats per minute. We look at the rhythm determination. We look at the P waves. The P waves are present in our lead 2, but we can see that there's something characteristic about your P wave. You have a small deflection here, you have another small deflection here, so it's like the P wave is bifid. So you have bifid P waves. We haven't yet talked about atrial enlargement. We haven't yet talked about left atrial enlargement, but this bifid P wave is often suggestive of P mitrale, which is seen in left atrial hypertrophy. We look at our QRS complexes. They are broad QRS complexes. We check our cardiac axis. Lead 1 is facing upwards, lead 3 is facing downwards, lead AVF is facing downwards, lead 2 is also facing downwards, so this is predominantly the left axis deviation. It's quite significant. We look for the presence of any bundle branch blocks. In V1, V2, you have these deep S waves. Even in V3, we have these deep S waves. Then to some extent also even in V4. Then in the lateral leads, we can see that there's notching of the QRS complex in the lateral leads, V5 and V6. We get this notching of the QRS complex. We can also see that in leads, in our lead 2 here, we can see that there's some notching of the QRS complex that is there in lead 2. In addition to that, we also see that there's some inversion of the T waves in lead 1. We can also see some inversion of T waves in lead AVL, some inversions of the T waves, in lead 1 and lead AVL. So most likely this person here has a left bundle branch block. We can also see the RS wave progression being poor. Remember, our RS wave progression in our lead 1, the QRS complex should be facing upwards. It is. In lead 2, it should be facing upwards, but it's facing downwards. In lead 3, it should be facing upwards. It's downwards. In lead AVF, it should be facing upwards. It's downwards. In V1 and V2, it should be predominantly negative. In V5 and V6, it should be predominantly positive. That's not the case. So you have a poor RS wave progression in this particular ECG. We haven't yet done hypertrophy, ischemia, or infarction. So most likely this patient has a left bundle branch block with a P mitrale. So most likely they may have some left atrial hypertrophy in this particular patient. So remember that our left bundle branch is going to be dividing into an anterior fascicle and a posterior fascicle. Remember that the right bundle branch doesn't have any divisions. So the depolarization in essence is going to spread via 3 main pathways. And the average depolarization is what we call our cardiac axis. It's going to be moving in a leftwards and downwards direction. And because your left ventricle has a bigger mass, it's going to influence your cardiac axis. So this is what I was talking about. We have our AV node here, bundle of his here, the right bundle branch, the left bundle branch, the anterior fascicle, the posterior fascicle. So there are 3 pathways. Your normal cardiac axis is in that fashion from 11 o'clock to 5 o'clock. So if the anterior fascicle of the left bundle branch actually fails to conduct, it means that the left ventricle now has to depolarize from the posterior fascicle. So if the anterior fascicle here is blocked, it has to depolarize from the other fascicle. So this means that it's going to cause your cardiac axis to rotate upwards. So this results in a left axis deviation. If your posterior fascicle of your left bundle branch block is blocked, usually it's not just blocked on its own, but if it does occur, you're going to see the opposite. You're going to see your right axis deviation because it's depolarizing from the other fascicle. Now, when you have a right bundle branch block, the cardiac axis usually is going to remain normal because, again, the mass of the ventricle is the one that's going to be influencing the cardiac axis. So we don't expect any deviation in the cardiac axis. So if both your right bundle branch and even your left anterior fascicles are blocked, your ECG is going to show your right features of right bundle branch block together with left axis deviation. We refer to this as bifascicular block, and this is a particular ECG pattern that's actually quite obviously going to be indicating that there's some widespread damage in the conduction system of the heart. Here's an example. Pause it, work it out, write down your answers. And here comes the answer. So as we can already see, when we look at this ECG. Of course, morphology sort of seems your ECG details have been taken care of. Your calibration, I assume, is already standard calibration because of this small rectangle there. Then we look at our general impression. As we can see here, they're narrow QRS complexes. It seems within the normal range. They're not broad, they seem within the normal range. When you calculate the rates, you can count the squares, but the rate comes down to somewhere around 90 beats per minute. Then in addition to that, we now look at the rhythm determination. Just a quick assessment, we can ask ourselves, are the P waves present? They are they followed by a QRS complex? Yes, they are. And a T wave, QRS complex and a T wave, QRS complex and a T wave? Yes, they are. So of course, our rhythm here is going to be sinus. So we calculate our rates roughly at around 90 beats per minute. We come now to look at our QR. You can actually even look at our PR interval in this case here, but I won't spend much time looking at that here. We look now at our QRS complex assessment. We look at our leads here. Lead 1 is facing upwards, lead AVF is facing downwards, lead 2 is facing downwards, so that is a left axis deviation, which is significant. So we have a left axis deviation here. We then come and check for any presence of any bundle branch blocks. So as we can see here, we come in lead V1. We can see that there is rabbit ears in V1. As you can see, we have this rabbit ears that we can see. We have this wave here, this tiny wave here on top, and then another wave here on top. So we have this rabbit ears that we can see in V1. We can see that there are these deep S waves that we can see here in lead V5 and V6. So usually this is a feature of right bundle branch block. So as you can see, that's another example that you can work out. So if the right bundle branch and both fascicles of the left bundle branch are actually blocked, this is quite similar to what we see in complete heart block. So it's just as we see in the main bundle of his that's failing to conduct the impulse. So we're going to take a short diversion and have a look at the PR interval, because I didn't talk about the PR interval. So remember that your PR interval is roughly around 120 to about 200 milliseconds, so that roughly translates to about 3 to 5 small boxes. Your PR interval could either be shortened or it could be prolonged. If it's shortened, it means that the impulse is coming close to where the AV node is, or the impulse is being conducted faster across the AV node by an accessory pathway that doesn't conduct it in the same time as the normal pathway. So we'll begin with our prolonged PR interval, which is one that is greater than 200 milliseconds or 0.2 seconds. So this is going to be signifying that there's some sort of a blockage. There's an atrioventricular delay. So heart block can be divided into 3 types. You have our first degree, second degree, and third degree. Our first degree here, you're going to have a fixed prolonged PR interval. That's the only thing you have. The PR interval is increased, it's prolonged. Second degree, you have some impulses being generated. Some of them are being conducted to the ventricle, some of them are not. It's like they're being filtered out. It's divided into 2 types. We have our morbits type 1, which is also known as the Wenck-Back block. So here the PR interval progressively increases until you get a P wave without any QRS complex afterwards. Then our morbits type 2, you have a fixed prolonged PR interval, but then you also have some dropped beats. You should clarify the frequency, whether it's a 2 to 1, 3 to 1, whether you have 2 P waves, 1 QRS complex, or 3 P waves, 1 QRS complex. Then our third degree heart block, we have our P waves, and our QRS complexes are not married to each other, so they are completely unrelated. So this is what first degree heart block actually looks like. So as you can see here, we can see that if we count the PR interval from here to here, from the beginning of the P wave, we have 1, 2, 3, 4, 5, 6, 7, 8. Okay, here 1, 2, 3, 4, 5, 6, 7, 8. Again here 1, 2, 3, 4, 5, 6, 7, 8. So we have 8 small squares. So the PR interval is prolonged here, greater than 0.2 seconds. Your QRS complexes are normal, so within 1 to 3 squares. Your P waves are normal, your rhythm is regular, so this person here is a first degree heart block. In terms of second degree heart block, I've even made it easier for you here to put the lines. As you can see, you have this progressive increase in your second degree heart block, which is your type 1, your morbits type 1. Your PR interval completely increases until you get here. You see that there's a T wave here, there's a P wave, nothing in between, another P wave. So we don't have a QRS complex here. So you have some dropped beats here. Your morbits type 2, we have a fixed PR interval. So as you can see here, it's prolonged and fixed from here to here, from here to here, from here to here. It's the same, but we see what's happening here. We have a T wave, we have a P wave, nothing, another P wave, QRS complex. So this is our second degree heart block. In third degree heart block, as you can see, there's no relationship between the P wave and the QRS complex, and they are occurring at their own rates and their own intervals. And you often are going to find out that the ventricular rate is going to be much slower than the atrial rate. So if it's the atrium, it's going to be beating at 60 to 100. If it's from the ventricles, 40 to 60. If it's an escape focus is junctional, it's less than 40. If the escape focus is ventricular, it's going to be less than 40 rather. If it's junctional, it's going to be between 40 to 60. Then your rhythm here is going to be regular, but the atria and the ventricles are beating separately. As you can see, there's no relationship between the P waves and the QRS complex. Even here, there's no relationship that you can make out between the P waves and the QRS complex. Moreover, here you have two P waves and a QRS complex. So the PR interval is going to vary greatly, and of course our QRS complexes here are going to be normal if the ventricles are being activated by a junction or escape focus. They may be wide if the focus is within the ventricles. So if you look at this, they are wide, so most likely the focus is coming from the ventricles that's generating this impulse. That's our third degree heart block. So remember, first degree heart block, it occurs between the SA node and the AV node, so it's within the atrium. Second degree heart block, it occurs, if it's type 1, it occurs in the AV node, so this is the only piece that is going to be conducting the heart and is going to be exhibiting the ability to conduct the electricity at different speeds. Type 2, Mobitz type 2, this one here is occurring at the AV node in the bundle of His or in the Purkinje fibers. Then the third degree can occur anywhere from the AV node down the conduction system, but there's a complete blockage of this conduction of the body. So what do we do? So first degree heart block, it's quite common. You may see it in some individuals. So think of acute MIs. You may also think of acute rheumatic fever if you're thinking of some possible causes, or sometimes even some drugs. There's no specific treatment that is indicated for these patients. Second degree usually is going to be indicative of heart disease, so it's seen in acute MIs as well. Mobitz type 2 and type 1 do not need specific treatment, but if you get a 2-to-1 block, it may indicate that they need some temporal or even some permanent pacing, especially if your ventricular rate is slow. The third degree heart block almost always is going to be pointing you towards some conducting tissue disease, so most often it's going to be due to fibrosis rather than ischemia. So these ones need a temporal or even permanent pacemaker. Then in terms of a shortened PR interval, remember your PR interval can shorten. So this means one of two things. It means that your P wave is starting somewhere closer to the AV node. So it means that it's taking a much shorter time to depolarize the AV node, and it's not starting off from the SA node. Because remember that the SA node is a fixed place, and some people's atria are actually even smaller than others. Or the second impulse could be starting off from the SA node by traveling through a faster pathway. And this faster pathway could be maybe an accessory pathway that is going to be associated with some sort of syndromes, like for example, Wolff-Parkinson-White syndrome, where you may also see delta waves. So in Wolff-Parkinson-White syndrome, you have this accessory pathway that conducts the impulse from the atria to the ventricles very fast. And of course, you're going to be seeing this characteristic J wave. Rather, characteristic delta wave, not a J wave. Characteristic delta wave, it looks like a J anyways. So you have this curvature of your QRS complex there. And of course, your PR interval is going to be quite short in this case. So this is usually suggestive of Wolff-Parkinson-White syndrome. I really hope you enjoyed this video on left bundle branch block. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.